Hi, class. This is Dr. Weaver, and I am going to talk to you about a couple of conditions, glomerulonephritis, the acute type, as well as the chronic type. Um, we have a lot to discuss as far as, I believe it's cystitis and possibly well, there's perhaps a couple of other topics we have to discuss. So I feel like we probably won't be able to get to this one in class. So I feel like doing a presentation voiceover would at least provide you with some really important information about this condition. So again, we're talking about glomerulonephritis. That's a hard one to pronounce. So I want you to review the anatomy and physiology of the kidneys. I believe you've done that for the renals part one test. And also we'll be talking about primary versus secondary. And this particular presentation will be talking about the acute type, and then we will go into the chronic type glomerulonephritis. So understand that the glomerulus is part of the kidneys that does the blood filtering. And so it's essentially defined as a cluster of nerve endings, spores, or small blood vessels, in particular, a cluster of capillaries around the end of a kidney tubule, where waste products are filtered from the blood. So it is the glomerulus that is responsible for getting rid of all that poison, if you will, all the waste products. Glomerulonephritis can be a primary condition, or primary related or secondary. When it is considered primary, it actually directly involves the kidneys. In the secondary, and in medical terms for secondary, we might say 2/2, secondary 2, just an FYI. You'll see that in my notes. Well, for secondary, there is a systemic disorder that involves the glomerular, such as patients with lupus or sickle cell disease, etc. Whenever you also hear me say etc., there's more information for you to read in that section. So, because I can't talk about everything, but just to give you an idea. Anyway, so these systemic conditions, the lupus, sickle cell being, or to name a few, they will be considered your secondary because their systemic effect, so to speak, will impact the patient's kidneys. So sometimes the glomerulus can be either injured or inflamed. Now, when the glomerulus is injured, it does allow protein and blood to pass through the filtering system and into the urine. And this would be considered abnormal. Patients should not have a large amount of protein or blood in their urine. You might see a small amount, but any significant amount will point to damage to the kidneys, in particular the glomerulus. Now, patients with glomerulonephritis, they can have an increase in their blood pressure. They can have progressive renal disease as well as edema, or swelling. When the kidneys are damaged, then they cannot produce an adequate amount of erythropoietin, which is a hormone. And therefore, these patients will experience anemia and as well as an increase in their cholesterol. Now, as you were told, I believe in last week's test information. Erythropoietin is a hormone that is produced primarily by the kidneys. It plays a key role in the production of red blood cells, which, of course, your red blood cells carry oxygen from your lungs to the rest of the body. I want you to also look at page 1376, table 67.1 for infectious agents associated with glomerulonephritis, such as streptococcus, as well as TB, and there's some additional, etc., some additional infectious organisms listed. Also, take a look at, again, page 1376, table 67-2 for other disease conditions. Glomerulonephritis can be found with conditions such as lupus, as I mentioned, and also amyloidosis, these multi-system type diseases. And there's some additional diseases you will find on that page as well that speaks about conditions where you will find glomerulonephritis. Urinary elimination can be altered too with glomerulonephritis. Typically, in acute glomerulonephritis, an inflammatory response affects the kidney tissues. And so whenever we talk about the kidneys being directly impacted, we're talking about a kind of an intrinsic type of injury, if you will. Intrinsic meaning within. In other words, it's not coming from some other system or systemic disease or what have you, but the renals or the kidneys itself are impacted with the acute type. All right. So patients, if an infection is discovered, or typically an infection is discovered before glomerulonephritis is found. And signs and symptoms will occur about 10 days after the infection is discovered. So we usually find that the patient does have an infection, and then the patient would not have signs and symptoms of glomerulonephritis until about 10 days after this infection is discovered. But these patients, they do recover quickly with the acute type from glomerulonephritis. Sometimes it is a bit difficult to determine whether or not a patient has primary versus secondary type of glomerulonephritis. Sometimes it might be hard to diagnose. And glomerulonephritis can also be caused by drugs that can impact the glomerulus, can be nephrotoxic, as we might refer to it as, or that we refer to it as, nephro meaning kidneys, and toxic to the kidney structures. And also it can be an inherited disorder. Now, as far as our assessment that we must undertake when looking at these patients, the history, of course, is very important. We want to ask these patients about there being any recent infections, whether that be a virus or fungi, etc. If the patient had any other illnesses that might contribute to acquiring this disorder. If the patient has surgery, particularly we are looking at these invasive procedures where a patient could have developed an infection, especially if sterile technique was broken. There's also systemic diseases we want to ask them about. Maybe the patient was diagnosed with lupus, maybe HIV or what have you. And also if the patient had any changes in urinary elimination. Maybe they're not voiding as much as they normally have in the past before becoming ill. We want to also inspect the skin for lesions, for incisions as well. This can indicate a possible cause of an infection. We want to also assess for signs of swelling, and the swelling you'll see in the patient's face, in the eyelids, in the hands, etc. And also we want to compare their blood pressure with their baseline. Obviously, with glomerulonephritis, we see a progression in their blood pressure, and therefore we want to make sure we're looking at that as well. Also, we want to look for any body piercings. You know, when you go to these places to get these piercings, they may not be using a sterile technique, if you will. And so this can cause infection. Look for also any fluid overload, any pulmonary edema that can occur with glomerulonephritis, such as fluid and sodium that would be retained. You're also performing a cardiopulmonary assessment. For example, the patient may develop an S3 gallop, JVD, jugular vein distension, and crackles as far as breath sounds, etc. And this is just, again, talking about possibly fluid overload. The patient's heart just cannot handle so much of this fluid because the patient's unable to eliminate like a normal person. We want to also assess the urinary system, such as urine color, amounts, etc. We want to weigh these patients daily because these patients with glomerulonephritis, if they're retaining fluid, they do have a tendency of gaining weight. And so we want to know that information and document it. So the blood pressure can be altered due to fluid and electrolyte balance issues and with fluid retention. Remember, when fluid is retained, when you have a lot of vascular volume, a lot of volume within the vascular system, the blood pressure is usually increased. And of course, when your vascular system is almost, well, not depleted, but low, then your blood pressure tends to be low. So you want to remember that, not only for this, but for other disease processes. Other significant signs and symptoms is nausea and vomiting from uremia. Uremia is a waste product that when when the eliminating or when the kidneys are unable to eliminate this waste product, then patients become sick. And of course, uremia is a poison that will cause these patients to experience nausea, vomiting. Then they might also experience fatigue as well. And there's some additional information for you to look at there as well. So let's take a look at some laboratory tools that we can use to determine, to rule in or to rule out this disorder. One of the biggest finds as far as when we utilize these tools is that they will reveal a significant amount of hematuria or blood in the urine, as well as proteinuria. And so, as I told you, sometimes we might find a small amount of blood in the urine as well as proteins, but a significant amount is abnormal, and further investigation is required. We want to obtain a urine specimen, particularly early in the morning, because in the morning is when the urine is most acidic, is more concentrated, and is filled with more intact formed elements at that time. And of course, this particular specimen can be more revealing than if you wait too late. Um, a 24-hour urine will show an increase in protein excretion. Remember, you should only have a very small amount of protein in the urine, but the 24-hour urine specimen will show an increase in protein excretion. Um, the serum protein, meaning the protein in the blood, will also be decreased because it is because of the injured glomeruli. Proteins are leaking from the vascular system and into the urine. So if you drew a blood level, checking the protein levels of your patients with this disease, you'll find that the levels are low. Um, Again, they're being lost due to damaged glomeruli. This will lead to fluid retention in the form of edema and also dilution. Um, so basically what happens is your proteins in the blood acts as a kind of a colloid pressure that keeps blood in the vascular space. And when you lose proteins, then you no longer have that pressure to keep the blood in the vascular space. And then, of course, fluids begin to leak into the surrounding tissue, causing edema. So this is where you'll see these patients who look quite swollen. You'll also find that these patients, their BUN and creatinine levels will be increased. Again, these are waste products, particularly proteins that the body or the renals, the kidneys cannot eliminate. The glomerular filtration rate, the GFR, what is it, tongue twisters, glomerular filtration rate, which we talked about as well, is typically low with these patients. So they're not eliminating, again, very well. And but remember now, with elderly patients, they already have a low GFR rate, sheer fact that they are elderly and things are on the decline, unfortunately. We want to also test to rule out immunity as an etiology or cause, such as HIV tests and other immunological diseases that might be impacting the kidneys, in particular the glomeruli. Other diagnostic assessment tool that we use is a biopsy, and this actually provides a precise diagnosis of a patient's condition because you're actually analyzing directly the renal or kidney tissue under a microscope. It is more definitive. Um, it can determine the patient's prognosis. It can allow for a more precise treatment plan as well, because you know what you're treating. You know what you're treating, then you know how to treat it. The treatment will be more tailored and more specific to your patient. Now, as far as managing the patient's infection, or the interventions that we will implement. We want to manage the patient's infections. It is important to prevent any complications and also provide appropriate patient education to your patients. As far as managing infection, we always want to treat the patient with the right antibiotic if an infection is the cause. For example, a penicillin. And of course, we try to do a culture and sensitivity to determine what organism we're dealing with. So when we're talking about the right antibiotic, this is one of the ways we come up with the right antibiotic is to do a culture and sensitivity. We're trying to find out what the organism is sensitive to. So when you look at a lab, um, you'll notice it when you're looking at a culture and sensitivity. You'll notice a number of R's and S's that are next to different antibiotics. When it says R as in Romeo, it means that the microorganism is resistant to a particular antibiotic. When it says an S as in Sam, it means that the organism is sensitive to that antibiotic, meaning that antibiotic can be effective against that organism. We certainly want to teach our patients about proper and frequent hand washing. That can minimize infections, certainly not only in patients and healthcare providers, but patients as well. Um, we want them to take all of the antibiotics in order to prevent any super infection. You know how some patients, they're prescribed an antibiotic for 10 days, but after maybe a few days, they feel good and they stop taking it. Well, then super infections can develop. So you want to instruct them or to teach them about completing the entire treatment regimen. Um, we also might have to provide drugs in order to purposely alter or weaken the immune system in order to decrease the inflammatory response. Um, you all won't go into this a lot, but uh, the immune system, there are certain steps in the immune system that, well, let me just say that when the immune system is more localized, let's say if you have a cut, something like that, the immune system is not so bad. But when you talk about an immune system that is more systemic, the inflammatory response can be more destructive than helpful. The inflammatory response, which is all a part of the immune system, is helpful in the beginning. But when the inflammatory response just goes on for a prolonged period of time, this is when tissue destruction occurs. And this is why we want to alter or weaken even purposely the immune system in order to decrease that inflammatory response, thereby minimizing destruction to the kidney tissues. Drugs such as steroids and cyclosporin, which are immune modulators, or drugs that has an impact on the immune system as far as lowering it or weakening it a bit, can be used. And there's some more, of course. If these patients are taking immunosuppressant medications, such as what I just named, these patients should be taught to avoid any new infections, avoid crowds, avoid hand shaking or anything that can where they can be exposed to infection. As far as preventing complications, these patients develop fluid and electrolyte imbalance, and they have problems. They have hypertension as well as edema. So therefore, the physician or the healthcare provider may have to order diuretics, and they may also he or she may also order sodium and water restrictions as well. This is part of the treatment. You know, you restrict sodium, then you avoid the fluid retention, and of course, the diuretics will help get rid of the additional swelling for these patients, which will lower the blood pressure as well and decrease the swelling. We want to also restrict protein as well as potassium in the diet, as these are actually increased in impaired renal issues. The kidneys just can't handle a significant amount of proteins, and so we have to minimize protein intake for these patients. And of course, since the filtering system is also altered, electrolytes such as potassium we have to restrict that as well, because once a patient begins to fail, renal failure, their potassium tends to increase. And therefore, we want to make sure we restrict potassium in the diet as well, because you just can't eliminate it like normal kidneys. Um, Now, this is especially so as far as proteins, because BUN, the blood urea nitrogen, is a byproduct of protein metabolism. So, if the filtering system is impaired, then you cannot eliminate this BUN or BUN, and therefore the patient is poisoned because we're talking about protein metabolism, the waste product from protein metabolism. These patients may also have what we call a plasmapheresis. And what this does, when the patient develops, when the cause might be perhaps autoimmune, where the patient has developed antibodies that could be attacking the kidneys, then the plasmapheresis treatment will actually remove the antibodies from the blood. It has like a filtering system. Because antibodies, again, they can affect or destroy. That's what antibodies do. They destroy or affect or impact the foreign, something that is considered foreign, a foreign invader, if you will. And so, for example, the body's not able to recognize itself, autoimmune disorder, and so you want to remove those antibodies that could be destructive to the kidneys. We want to also observe for any signs and symptoms of uremia. Uremia is also a waste product that is typically removed by normally operating kidneys. But when the kidneys are impaired, the uremia increases in the blood. It is poison, it is a toxin, waste product that leads to signs and symptoms of nausea, vomiting, anorexia. If we cannot control the uremia with nutritional therapy, then hemodialysis will be warranted in order to remove the toxins. So what we do is we try to manage this condition with nutritional therapy, and fluid management, but sometimes that's just not enough, and therefore hemodialysis would be warranted. Now, these patients do become fatigued pretty easily, and they have the anemia going on and everything, and just overall, all of their systems are just being impacted when they are developing renal failure. And so we want to teach these patients about balancing rest with activity. You don't want to rest too much. You don't want to be overly active either, but there should be a balance so as not to over fatigue your patients. These patients should, you may want to provide some relaxation techniques, perhaps music therapies and what have you, maybe crossword puzzles or anything that some diversional activity that can reduce their emotional distress. I'm sure you can imagine these patients have a lot to think about, especially if their renal status deteriorates to the point where they might have to go on dialysis and possibly even need a kidney transplant. Major life-changing situation. We also want to provide the patient with education. That is also important. One of my main bullet points here. We want to this teaching. It should involve information about the medications that they're taking, the mechanism of action, in layman's terms, of course, indications. Why they're taking the medication. You should be talking about the side effects and what to report to the physician, and any nursing implications or responsibilities, such as taking your blood pressure, weighing yourself, and so forth. You want to make sure you're doing all that with your patients. As we want to talk to them about the diet. Remember, as far as diet, low potassium, low protein diet. because the kidney functions is impaired. Um, Fluid restrictions. The healthcare provider may place this patient on fluid restriction, and the patient must adhere to it. Otherwise, they will retain too much fluid and cause other problems, of course. Daily weight is important to talk to them about. Same time, same day, same amount of clothing. Uh, excuse me, and also to notify the healthcare provider about any increases in their blood pressure as well as their weight. We want to notify the healthcare provider early so that they might intervene early and reduce any further worsening outcomes. We want to also talk to them about hemodialysis, perhaps any kind of teaching as it relates to it. In anticipation as well as once they're on dialysis. So patient teaching is very important. And these patients, of course, if they have hemodialysis, then they'll likely have a vascular access device, which you want to make sure that does not become infected, no restrictive clothing around that device, whatever information that is important so that they can safeguard that access device. There's also a type of glomerulonephritis called RPNG. It's a rapidly progressive type of disorder, a type of glomerulonephritis. On page 1377, it's on the bottom right-hand page. And basically, with this one, this condition is also known as crescentic glomerulonephritis due to the crescent-shaped cells in the Bowman's capsule. I mean, you know how a regular cell looks, but these cells look more crescent-shaped, which is abnormal, obviously. These patients should also be taught about ACE inhibitors, which goes back to teachings about their medications. But specifically, we talk about this one because remember, with ACE inhibitors, you're stopping that ROS system from taking place. And so that prevents sodium and water retention. There's actually sodium and water excretion, but these patients are holding on to potassium. And as a result, of the fact that it does hold on to potassium, you need to make sure that you're really watching their potassium levels because because their kidneys are not working as well. Then we need to that much more watch their potassium levels with an ACE inhibitor. And also the blood pressure, whatever the nursing responsibility is, particularly the blood pressure with an ACE inhibitor. May want to even place these patients on a monitor if they're not already, or suggested to the healthcare provider in charge of the patient's care. I want you to also look at page 1383 to 84 about nephrostomy tubes. It talks about the pre-op, the procedure itself, and also the post-op care. So just go ahead and take a read of that information. Pretty easy stuff to read. And if not, of course, ask me any questions. Now, when caring for these nephrostomy tubes, in your reading, you'll learn what issues that should be reported to the surgeon or whoever performed the procedure. You should know what to report. For example, if it's not draining properly, if there's maybe bright red blood in the tube, or if there's urine leaking around the entry site, whatever the issues are, then this needs to be reported ASAP. So that is it regarding the acute type. So let's go ahead and have a quick discussion about the chronic glomerulonephritis. This particular condition, it develops, it takes years to decades to develop. Symptoms may involve a mild proteinuria, hematuria, hypertension, fatigue, edema, signs and symptoms. And so, with this condition, the exact cause is not known, or the etiology is not known. So, chronic glomerulonephritis is also referred to as chronic nephrotic syndrome. Renal tissues tend to change, possibly due to infection, or the patient might have hypertension. There can also be inflammation from an excessive immune response. Remember, I told you the immune response, which involves the inflammatory response, can be overwhelming for the body. When the inflammatory response is of short duration, it's not that much of a problem. But sometimes the immune system, the inflammatory response, go into kind of an overdrive, and it does cause quite a bit of tissue destruction. So what essentially happens here is renal tissue, they tend to atrophy, and atrophy meaning it shrinks, or the body tissue or the organ tends to waste away with this particular condition, the chronic type. And then, of course, the nephrons become non-functional. And of course, you cannot regulate your water when your nephrons are impacted. Now, I did provide you a definition of what the nephron actually does. It is the basic structure and functional unit of the kidneys, and it does regulate water and soluble substances in the blood by filtering the blood. And it also reabsorbs what is needed, excretes what is not, what it does not need into our urine, but it also reabsorbs those essential elements. So when the nephrons are destroyed, then you do not excrete these items, and of course your body maintains them, making the patient even that much more ill. And so it's the nephrons, its function is vital to maintain homeostasis of the blood volume, blood pressure, and also the plasma osmolarity. When we talk about plasma osmolarity, we're talking about whether or not the blood is either concentrated or diluted. If it's concentrated, that means it's more elements to plasma. And if it's diluted, you have more plasma and less elements in the blood. So a biopsy of the tissue, it shows a late stage, or the late stage of the tissue that is biopsied. And so the glomerular, it would show glomerular changes, it would show cell loss, there's protein and collagen deposits, and also fibrosis of the renal tissues. And this is what you will be able to see under a microscope, which should point to chronic glomerulonephritis. A microscopic view of the renal tissue show immune complexes and inflammation. So you'll be able to tell that some inflammatory or immune complex response did occur, and this is what is destroying the renal tissues. Now, as the nephrons are lost due to whatever the cause is, then the glomerular filtration will decrease. And so your filtering system is impaired. These patients will have hypertension and renal arterial sclerosis or hardening of the nephrons. So of course, again, they will have an increase in their blood pressure with this condition. Damage to the glomerulus will cause, as we spoke on the acute type, protein leakage into the urine. Um, so when you do an analysis, this is what you'll see, a lot of protein in the urine that shouldn't be there. With chronic glomerulonephritis, it will eventually lead to, unfortunately, end-stage kidney disease for these patients. And so with this particular patient, the chronic type, we want to, again, go into the history. The history is very important. And this is why it's so important for you guys to learn about these disease processes and what have you, because you know what right questions to ask. And this is a more focused assessment. You're looking specifically at the renal system. And which may include, well, it's focused, but yet there's some other systems that might come into play when you think about it. But anyhow, you want to ask about other health problems, recent exposure to infection. You want to talk about or ask about any urinary elimination patterns. Again, we're dealing with the urinary system. We want to assess for systemic circulatory overload or fluid overload, any uremic symptoms that I discussed previously. And we want to also assess the pulmonary system because they might be holding on to all that volume, developing crackles and shortness of breath, maybe even pulmonary edema. These patients can also experience heart failure because now the heart has to deal with so much volume. You certainly want to be looking for signs and symptoms of heart failure with these patients. Some of the diagnostic tools that we might use, 24-hour urine collection. Remember, we're looking at proteins, excessive amount of protein. We're also looking at the BUN and creatinine. Remember, these are increased when the renals are impaired. Phosphate levels might also be increased, or they could be low. But remember, calcium and phosphate have a reciprocal effect. So if the phosphate is up, then the calcium will be down, and if the phosphate is down, then the calcium will be up. I can't remember right off if the phosphate levels, and that depends on at what stage you are in renal failure. I want to say that typically the phosphate level will be high and the calcium level is low. And the reason I say that is because sometimes we give these patients a medication called Foslow. And so what that does is it lowers the phosphate level. But remember that reciprocal or inverse relationship, I should say, would cause an increase and bring the calcium back up to more normal levels. These patients may also have an arterial blood gas. Remember, when these patients have renal issues, they might be in metabolic acidosis because remember, they're not able to excrete the hydrogen ions, which is the acid. They're not able to excrete the hydrogen ions, and therefore they're holding on to the hydrogen ions, meaning they become more acidic. Their blood becomes more acidic. The pH is very low. And so these patients are said to be in metabolic acidosis. Also, these patients might have a kidney x-ray or CT scan. And this usually will show a very small kidney. Again, with these patients, you want to look for fatigue and lethargy. We're looking at the urine output. We want to assess their neurological systems, such as impaired cognition. Remember, this is caused by waste products in the blood, etc. We want to look at their pulmonary assessment, again, the crackles, lung crackles, respiratory rate, etc. We're looking at their weight, their blood pressure. which can be increased with this condition. Um, and also, as far as cardiac, we are looking for any S3 heart sounds, JVD. Remember, these patients can be going into heart failure, edema of the lower extremities, in particular feet and ankles, etc. We want to also assess for uremic signs and symptoms. They can be slurred speech, ataxia, tremors, asterixis. What this is flapping, tremor, fingers, or inability to maintain a fixed posture with the arms extended and the waist and the wrist rather, hyperextended. And so this is just a test that your healthcare provider will perform, which could indicate your uremic poisoning. We want to also look at the skin for any yellow color, any texture changes to the skin, any bruising. Also ask these patients if they're itching, if there's any excoriation from scratching, and there's more information there. When these patients develop what we call uremic frost, and when the uremia increases so much, it does begin to seep into your skin tissues, causing quite a bit of itching. So certainly something you want to look for. So we talked about some of the diagnostic tests with the previous one. Even with this one, we want to monitor the GFR rate, which would be decreased here. The creatinine and BUN would be elevated because there's a poor elimination of waste. The kidney function is decreased, and it does or impaired. And because of this impairment, it does disturb the patient's fluid and electrolyte balance. Sodium retention is normal, but dilutional sodium from fluid retention can occur. In other words, if the renals or the kidneys cannot eliminate the fluid, then you're holding on to a lot of fluid. And so fluid to the sodium element, or the sodium would be low compared to a significant amount of volume overload, which is not good, of course. These patients may have signs and symptoms of oliguria, which is about 400 cc's of urine in a 24-hour period, which is definitely no good. There would also be an increase in the potassium, so these patients should be placed on a cardiac monitor because they do tend to have cardiac dysrhythmias as a result. The phosphate levels is usually high. Oh, well, I have that here. So the phosphate level is high, typically greater than 4.7, so know your ranges on your electrolytes. And the calcium level is low. And as I mentioned to you earlier, didn't realize I had this written here, but it has an inverse relationship. If the phosphate is high, the calcium is low. So this is why they give them Foslow, in order to decrease the phosphate levels and increase the calcium levels. Hopefully normalize the calcium levels. There's also disturbance in fluid and electrolyte with acidosis. Again, this is due to hydrogen ions retention and loss of bicarb. So these patients, they retain the hydrogen ions, which increases the acidity of the blood, and they're losing base or bicarb. Remember, bicarb is what buffers that acidic environment, which you hope to lower the acid levels in the blood. When the hydrogen ions increase in the blood because of failure of the kidneys to excrete an adequate amount, then these patients would go into acidosis. Now, an increase in hydrogen ions also means that these patients, they're going to have a high CO2 level in the blood. And the brain would make the patients breathe out the CO2, but they're going to breathe much more faster. because you're trying to eliminate the CO2. If you can eliminate enough CO2, then you can possibly lower the acidosis, but that's not a system that is very effective. Your kidneys are more effective in eliminating acid, but it takes some time, sometimes days before that system works. So you have to do other things like give these patients synthetic bicarb to hopefully buffer that acidic environment. So that increase in respiratory rate is just a respiratory compensatory mechanism. As I said, it's a very poor mechanism, so it doesn't last very long. If compensation is correcting the acidosis, an arterial blood gas will show a pH between 7.35 and 7.45. So you should always know those ranges. If the pH is less than 7.35, then essentially the respiratory compensatory mechanism is not working. So as I said, the respiratory compensatory mechanism is a very poor system. The renals, the kidneys are much faster. Remember, it is the lungs and the kidneys that deals with your pH. All right. So you certainly want to make sure these patients are getting the right medications, in particular the bicarb, when their acid levels are very high. So as far as continuing our interventions, so how we respond appropriately to these patients, we must focus on slowing progression of the disease. We must also prevent any complications. Now, management is systemic. And it does consist of perhaps any dietary changes. Remember the low proteins, low potassium. There's also fluid intake sufficient to improve blood flow to the kidneys. We want to make sure there's enough fluids, that is if the patient is still urinating, in order to improve blood flow to the kidneys, in order to prevent any impairment. But of course, we must know the patients, how much they're actually voiding or urinating. Drug therapy to control the uremia. So you should know your signs and symptoms, as I've already gone over. Eventually, these patients will require dialysis or a transplant if they are impaired beyond what can be expected. If you can also read page 1383, well, I think I told you about this one. Read 1383 to 84 about the nephrostomy tube care. So make sure you read that. We want to also observe for signs and symptoms of dehydration and infection, as well as active bleeding. Remember, in renal failure, especially the chronic type, the clotting factors are off as well. So we want to certainly look for any bleeding issues with these patients. And that is actually it. I'm not sure how long this one, this one lasted for about 53 minutes, so it did last a little longer than I expected, but I wanted to be a whole lot more deliberate in going over the information with you all. So hopefully this is will be informative enough for you that you'll understand what happens with glomerulonephritis, the acute as well as the chronic type. Please let me know if you have any questions about this discussion. Thank you.